Nasief, it's fine. You can.
All right, so I'll be speaking about a topic that's my info is based on, and it's on gastroesophageal reflux. It's a presentation that I had delivered within our division at UCT, sort of towards the end of last year. I am a bit rusty, so please forgive me. I haven't read this for a while now, so please bear with me. This topic has been presented from these various review articles and articles that I've taken from the major societies and the major guidelines. But just to start with, in terms of gastroesophageal reflux, it is the effortless movement of stomach contents into the esophagus, which causes troublesome symptoms and or complications. And normally what happens is that the relaxation of the lower esophageal sphincter allows food to pass. It allows burping, which is the selective gas venting. It allows some distal acid exposure, which is physiological. And transiently, there is this lower, sort of the relaxation of the lower esophageal sphincter, which is not swallow dependent. It is in response to gastric distension. It's there for about slightly more than 10 seconds, and it does enable gas venting. So we have normal anti-reflux mechanisms, where there is esophageal acid clearance by peristalsis, where saliva is able to neutralize reflux acid, and there is this postprandial pocket of acid. And the crural of the diaphragm is very important in this mechanism, where it acts as a pinch cock for the lower esophageal sphincter, as is depicted in this diagram, this very mechanical pinch cock. And essentially, there's this failure of these anti-reflux mechanisms, where even subtle alteration, there's loss of your transient low esophageal reflux. There's lack of esophageal acid clearance by peristalsis that affects the postprandial pocket of acid, as well as the development of hiatus hernia. These are the factors that may contribute to failure to the mechanism and pathogenesis of gastroesophageal reflux. It's also worsened by weight gain. And in this particular study from 2006, it has shown that patients that had a raised BMI, especially a BMI more than 30, had a raised gastroesophageal reflux, gastroesophageal pressure gradient, and that increased the amount of reflux that these patients had experienced. And we've seen this in clinical practice, where certainly symptoms of GORD is more elevated in patients that have a raised BMI. So, as shown in this study, an increased abdominal diameter it is an independent risk factor for GORD symptoms. So if you look at physiological reflux that happens normally versus pathologic reflux, I've said that physiologic reflux is postprandial, it's asymptomatic, it's transient, it's really even nocturnal, and we know that with patients that have pathological reflux at night often works by waking up patients, often mimicked with ischemic chest pain. That's a feature of pathological reflux, but physiologically, hardly it happens at night. When we do our further pH testing, we find that the acid exposure time is less than 4%, and on on further testing, there's less than 40 reflux episodes in a 24-hour period. Whereas pathologic reflux is frequent, it's symptomatic, it's bothersome, typically happens at night, often nocturnal symptoms. When we do our pH testing, the acid exposure time is more than 6%, and on impedance monitoring, is more than 80 episodes over a 24-hour period. So the typical symptoms of gastroesophageal reflux is, firstly, the two cardinal symptoms is, number one is heartburn, and number two is regurgitation. So heartburn is this burning sensation in the retrosternal area. It's behind the breastbone. And regurgitation is the perception of the perception of flow of reflux gastric content, which may be food, which may be liquid, which may be acid into the mouth. And if these two symptoms are dominant, 70% of patients will have reflux. And about 50% of patients with GORD report that heartburn, regurgitation is being the most troublesome symptom. Importantly, those are the typical symptoms. The atypical symptoms are important symptoms to be aware of, because patients may not present in a very typical manner, And those of us that have done lots of internal medicine, we've certainly seen this. And probably top of the list is chest pain. And I alluded to this earlier. You know, a patient with reflux can present with chest pain. It can even occur after exercise. But in further testing, often normal ECG, normal troponins. So certainly chest pain is one of the atypical symptoms. Dysphagia, and I put dysphagia in red because dysphagia is one of the red flag symptoms in patients with reflux, often indicating a possible stricture. Other symptoms include bloating, belching, a chronic cough, this typical globus, this hypersalivation, water brash, this globus sensation in the throat, this feeling of food being stuck in the throat, water brash, the hypersalivation, epigastric pain, nausea, or extraesophageal symptoms. Now, in terms of the alarm symptoms, these are very important symptoms to think of in people that have patients that have gastroesophageal reflux. So the alarm symptoms are if there's new onset dyspepsia in patients more than 60 years, if there's any evidence of gastroesophageal bleeding, patient has iron deficiency anemia, anorexia, unexplained weight loss, dysphagia, adenophagia, persistent vomiting, or malignancy in a first-degree relative. So whilst these are alarm symptoms in any setting, it's particularly important in the context of gastroesophageal reflux, but it also holds true for other causes of upper GI symptoms, including peptic ulcer disease. So the consequences of untreated GORD is that firstly, it can result in reflux esophagitis. It can cause a peptic stricture. It can cause, with time, changes in the lower esophageal mucosa to cause your Barrett's esophagus and ultimately forming esophageal adenocarcinoma. Important to note is that there's important mimics of GORD. So even though people have symptoms of acid reflux, as I've indicated, there is an important differential diagnosis to think of. That's quite a long list, as you can see, but these include important achalasia. Eosinophilic esophagitis is particularly important, especially in the right patient profile, especially patients had symptoms of atopy, if patients possibly had bolus obstruction, and important to note, if patients have GORD symptoms, they have dysphagia, important to consider eosinophilic esophagitis. We do not uncommonly see pill esophagitis. More uncommon causes would be esophageal diverticular, and we saw, I think, Galia showing a case of that last year at the Fellows weekend. Esophageal strictures, cancer, but also other causes, other functional causes, gastroparesis, rumination, bowel acid reflux, but also lower on the list is coronary artery disease and functional dyspepsia, including peptic ulcer disease. So in terms of refractory GORD, and this is an important concept to be aware of, especially as these patients may be taking long-standing proton pump inhibitor, and it's defined as the persistent, troublesome GORD despite optimized PPI treatments, which is defined as the persistence of symptoms of GORD despite the patient taking a PPI twice a day for 8 to 12 weeks. Most of the literature takes 8 weeks. In our unit, we look at 12 weeks. Certainly, most of the papers that I looked at for this presentation, it was 8 weeks. Symptoms occurring 3 times a week, but also importantly, to make this diagnosis, there needs to be objective evidence of GORD that I'll speak about shortly. And importantly, in this category of patients, up to 40% of patients have inadequate symptom relief with PPI. This issue of sort of refractory GORD, it causes severe and significant morbidity. But importantly, as Dr. Fredericks said at the start of the presentation, it's a very important GORD and persistent GORD. It's a very important cause for presentation to a gastroenterologist, and I would argue it probably is bread and butter for any gastroenterologist. In terms of the pathophysiology of refractory GORD, number one is issues with the anti-reflux barrier, where there is decreased mucosal barrier integrity that's resulting in lower esophageal sphincter resting pressure. There's transient relaxation of the lower esophageal sphincter. Number two, there's impaired esophageal clearance, where there's decreased clearance of acid and bolus from the esophagus. And this may be due to altered peristalsis, a hiatus hernia, or alterations in salivation. Importantly is delayed gastric emptying. And the mechanism here is that increased gastric distension results in transient relaxation of the lower esophageal sphincter, with ultimately causing reflux of gastric contents. An important concept an important pathophysiology to understand, especially when the scope is normal, is this concept of esophageal hypersensitivity and hypervigilance. And the mechanism here is that there's an increased perception of different stimuli. This may be acid, it may be temperature, it may be mechanical distension, it may even be electrical stimulation that causes central and peripheral sensitization, that causes widening of the distal intercalated spaces, resulting in exposure of your subepithelial nerves to the acid. And this may be this issue of esophageal hypersensitivity, which is an important concept, and may be aggravated with chronic stresses. And this is another uncommon problem in our day-to-day practice. Important to note is that several drugs is commonly associated with esophageal damage, as in this whole issue of pill esophagitis. The drugs are listed there include statins, non-steroidals, which is common, iron medication, which is common, calcium channel blockers, etc. In terms of the potential causes of refractory GORD, number one would be, looking at the compliance of a patient on a PPI. As I've said, the definition is patients that are not responding to a PPI. So the first thing would be to ensure that what's the compliance in terms of the dose? Is a patient taking daily dose or BD dose? Number two, the timing of the PPI. When does a patient take the PPI? It should be taken ideally 30 to 60 minutes before a meal. And from the papers that I have reviewed, I found up to half patients, actually 54% of patients, have incorrect PPI usage, where only 8% of patients took the PPI 30 to 60 minutes before a meal. And many patients stop the PPI when the symptoms improve. Possible reasons for this may include the issue of poor compliance is knowledge of insight around the condition, the side effects of this growing concern of side effects of PPIs, but also mild symptoms of PPI, including diarrhea. The second potential mechanism for refractory GORD would be the PPI metabolism. This is important because this may differ from person to person, whereby there is pharmacological activity of PPI amongst different patients. And there is a genetic variability in the cytochrome P450. And there's been two types that have been identified, the cytochrome P2C19 and the cytochrome P3A4. And from that, there's three different phenotypes that has been identified. Number one is your rapid metabolizer, where patients rapidly metabolize the PPI, the intermediate metabolizer, and the slow metabolizer. And the meta-analysis that looked at showed that 60 to 70% of Caucasians, as well as Asians, are rapid metabolizers with lower response to a PPI. So they rapidly metabolize the drug, lowering the drug levels and a shorter therapeutic impact. Also to note that is there potential difference in the PPI agents? If you listen to many of the reps over the years, they've always led us to believe that one PPI better than another. The jury is probably still out on that, but from multiple large patient cohorts comparing different PPI preparations, there has been no evidence of superiority of one PPI over the other. A fourth mechanism of refractory GORD, and this is important I think it's important for the pathophysiology, is patients they're on PPI, but they may still have persistently weakly acid or non-acid reflux. So weakly acid reflux is defined as a pH between 4 and 7. A weak alkaline reflux is a pH more than 7. So often this is what you find when you do 24-hour pH testing. And what we found was in patients with refractory GORD, 30 to 40% of patients have either had weak acid reflux or weak alkaline reflux. The mechanism here is that there is distension of the esophagus that results in increased reflux volume and ultimately causing esophageal hypersensitivity that I spoke about earlier. So there's weak acid reflux, and it's thought that pepsin migrates into the esophagus where it has a proteolytic effect. And the effect seems to be most pronounced with a pH between 1.9 to 3.6. But we've seen that there is activity of the pepsin in this category in this cohort of patient with pHs more than 6. Bile acid reflux. Bile reflux is weakly alkaline. And patient had a gastrectomy, this may be a problem, where there's bilirubin, an acid that refluxes and damages the esophageal mucosa, and something to consider in patients that are post-gastrectomy and they haven't responded to the PPI. So the concept of bile acid reflux. So once we've seen these patients, what is the workup? I've listed here the possible tests to consider, and I'll discuss them in greater detail. So first, we'll consider gastroscopy. Number two, we discuss pH monitoring. We'll discuss a 24-hour pH study, 24-hour pH impedance, as well as just touch on this whole concept in the literature of wireless pH monitoring that we haven't really used in our setting. I'll speak about reflux manometry, and Sasa often does the manometry at the same time that she does the ambulatory pH, mainly to look at the mimics of GORD. I'll speak about barium swallow and then briefly gastric emptying study. So in terms of gastroscopy, gastroscopy should be considered, especially in patients where there are alarm features that I spoke about earlier. For men more than 50 that have chronic GORD for more than 5 years, especially with the consideration of the risk of developing Barrett's reflux. But also importantly, if your patient meets criteria for this BD-PPI, they haven't responded to BD-PPI for more than 8 weeks, they have refractory GORD, these patients should receive a gastroscopy. For patients that have typical GORD symptoms, we don't routinely recommend a short history of reflux symptoms. We don't typically recommend a gastroscopy. Important to note that we don't just do the G-scope. Biopsies are required if we are considering the diagnosis of EOE. And from the papers that I looked at, there's about a prevalence of 0.9 to 4% of EOE in people with refractory GORD. And it's more so if the patient had the symptom of dysphagia. If there's no dysphagia, just pure reflux symptoms, the pickup of EOE is much less. The G-scope, the biopsies may just show non-specific inflammation, but it may be very helpful. Depends on if hernia. When you do a G-scope, you may not have found objective evidence because patients often appear on the PPI, but if they have a hernia, with reflux symptoms, that often may be very useful. On a gastroscopy, refractory GORD, in terms of the objective evidence, it's diagnosed with our Los Angeles classification, typically C and D. I'm included B because in the newer literature, they are starting to include Los Angeles B. If there's a peptic stricture or there is a long segment of Barrett's esophagus. So just to remind us, when you do a scope, in terms of the ALE classification, grade A, grade B, grade C, grade D. So typically grade C and D is if there is essentially more than one mucosal break that covers more than 75% of the circumference, and D being circumferential. Just for my fellow colleagues, the other fellows, we do a G-scope, just some pictures that I managed to prepare for when I presented this. In the first slide, it's a normal lower esophagus. You may find number 2 where there is candidoesophagitis. Number 3, we can see there's a very tight stricture, and that's your typical peptic stricture, and that is a marker, and that is typically seen as an objective marker of reflux. Number 4 is a typical feature seen in Barrett's, the tongue of Barrett's. And then as you move in this typical feline appearance, this trachelization of the esophagus, we're seeing 5, indicative of EOE, reflux esophagitis, as I've just shown in the 6th picture with the ALE classification. But also important to note that you may have this diverticulum that may mimic the symptoms with the diverticulum adjacent to the lumen. And finally, the presence in slide 8, the presence of a adenocarcinoma of your lower esophagus. We're moving on to we've examined the patient, we've done the scope. We are concerned that this patient does have significant reflux esophagitis. Concerned the patient may have refractory GORD. We may proceed to what we refer to as ambulatory reflux monitoring. And in our setting, the sort of what we've used, the sort of the bedrock of it has been your 24-hour pH. At G-EHCO, SASA does do the pH in selected patients, the pH impedance, and the whole Bravo to the whole sort of 96-hour wireless monitoring. More and more that's gained traction in the literature in the last 5 to 10 years. So ambulatory pH monitoring, it's the gold standard for refractory GORD, especially patients that have normal symptoms, atypical symptoms, but also done prior to anti-reflux surgery. Important to note that when we do ambulatory reflux monitoring, we need to know, is it done off PPI or on PPI? Now, if there's been no prior evidence, the scope was normal, but the symptoms is really bad, and the symptoms is really bad, we are looking for a diagnostic test. We're looking for our pH study to tell us, is there objective evidence on the pH study of GORD? In that setting, we'd want to sort of have the patient go through a process where at least 7 to 14 days before the pH study is done to stop the PPI. But however, once the diagnosis has been established, we've seen on the G-scope, there's a very clear, the G-scope has been diagnostic for GORD, the diagnosis is established, or there's prior objective evidence of GORD, we can then do the ambulatory pH monitoring on the PPI. In terms of the actual pH study, what happens is that there is a catheter that is placed. One is placed within the stomach, and the other marker is 5 centimeters above the lower esophageal sphincter. It's placed usually intranasally. Patient wears it for 24 hours, and at G-EHCO, this is how it looks. As you've seen, this is the probe and the marks on the 24-hour pH study that's marked over there. And once we interpret the 24-hour pH study, we are number one looking for evidence of excess esophageal acid exposure, as in over 24-hour period. Has that acid exposure been at a level that is significant? Now, the acid exposure time, it's the most validated and the reproducible metric that has been shown for diagnosis of gastroesophageal reflux. And it's defined as the percentage of time that there are reflux episodes or acid in the esophagus. So normally, I spoke about earlier of normal physiological reflux. If you did a pH study on these patients, it would be less than 4%. For pathological reflux, we've now confirmed the diagnosis is that the acid exposure time is more than 6%. Once it's in between 4 and 6%, that requires a further testing. Often that's where we tend to do your pH impedance. And this requires often clinical correlation. This slide just indicates, this is just one of the slides looking at the pH and looking at the acid exposure over 24-hour period. We can see in this patient, the pH of 4. Most of this reflux episode was between 4 and 6. And there were a few episodes of reflux above a pH of 6. Now, moving on to the 24-hour pH impedance study. This measures the direction of flow, regardless of the flow of the acid that is refluxed, and it's regardless of the acidity. It differentiates between a reflux episode versus a swallow. It can tell you, if it's acidic with pH less than 4. It shows you if it's weakly acidic, where it's pH 4 and 7, or if it's alkaline. This is our 24-hour pH, the probe that we use, and the electrodes that is placed on the probe. And this 24-hour pH impedance study, it measures the total number of reflux episodes over 24-hour period, right? And it's defined that if it's a positive study, it's abnormal if there's more than 80 episodes over 24-hour period. It's less than 40 if it's normal, and it's been 14, 80 it is borderline. And this is often mainly used, this pH impedance used often as an adjunct when the acid exposure is indeterminate, often between 4 and 6. So importantly, when we place this nasal catheter, the patient the patient, there's a mechanism where patient can indicate if they have symptoms. So over 24-hour period, we will measure the actual catheter will tell us what the pH is, but also there will be a symptom correlation. And the symptom correlation is very important. So we look at the symptom association and we look to see, is there a temporal relationship between the reflux episodes and the symptoms? So for that, we use two big metrics. Number one is your symptom index, which is the ratio of symptoms within 2 minutes from the reflux episode. And if it's more than 50% correlation, that's positive. And it doesn't account for the total number of reflux episodes. In terms of your symptom association probability, that is the probability that is calculated that the symptoms is associated with the reflux events. And a positive symptom association probability is a p-value of less than 0.05 or SAP that's recorded more than 95%. And you require a minimum of 3 symptoms for this analysis. So on this graph, I've correlated the two. I've looked at your acid exposure time, right? Where on your where you're looking at the pH more than 6 or pH under 4, and then correlating the acid exposure time correlating with your symptoms. So if your acid exposure time is more than 6 and it correlates with the symptoms that the patient, they press the button and it's correlated with the symptoms, that is diagnostic of GORD, right? Or however, if the pH is more than 6, but still there were no symptoms, that is still good. But important to note, this often the scenario is that, the pH was, the patient had lots of symptoms, but the pH was less than 4, right? In terms of acid exposure time. In that setting, it's called reflux hypersensitivity. That is probably one of the commonest diagnoses that is made when patients have a 24-hour pH study. If the pH is less than 4 and there's no symptoms, then it's just called functional heartburn. Just to mention this Bravo study, you will see it in the literature, where it measures your pH over a prolonged period, 48 to 96 hours. And typically what they do is that they take the 2 best 24-hour periods for analysis. All right, this is the Bravo system. We don't have it at Grooteskiel. I'm keen to hear if it's available in other parts or used in other parts of the country. And essentially, for the Bravo system, this capsule, this Bravo capsule, has to be placed endoscopically, as in the slide that I've just shown. And as I said, this is how it looks endoscopically. You've done the scope. That's how it looks. Now, in terms of the Lyon consensus that the consultant spoke about just as we had started this, conclusive evidence for pathologic reflux is we've done an endoscopy and there is on LA grade CMD esophagitis. There is long segment Barrett's and there's a peptic stricture, right? That's an endoscopy. You've done a 24-hour pH study and the acid exposure time is more than 6%. That is conclusive evidence as per the Lyon consensus. Borderline inconclusive evidence is defined. You've done a scope as LA. This is LA A and B. I'm not sure if the Lyon consensus has been updated to cater for this for the LAB that's now in lots of the newer literature. If it's that borderline, I spoke about the acid exposure time between 4 and 6%, or the reflux episode between 40 and 80. That particular borderline, that is borderline as per the Lyon's consensus. Once the acid exposure is less than 4% or less than 40 reflux episode in a 24-hour period, that is evidence against pathologic reflux. And the previous slide where I gave that table, the reflux hypersensitivity or the functional heartburn should be considered. I'm moving on to manometry, and at Grooteskiel, SASA does often every patient that she does a pH study, she does a manometry at the same time. And important to note is that a high resolution manometry is not diagnostic of GORD, but it's important for excluding major esophageal motility disorders which can mimic GORD, most notably achalasia. It also can help, often it can help with placement of the catheter for the 24-hour study. It can be used as an adjunct to diagnose GORD. But if once you've referred a patient for reflux surgery, often the surgeons they would want a manometer as part of the pre-op evaluation. It's inconclusive manometry in the concept of post-swallow induced peristaltic wave, or the concept of mean nocturnal baseline impedance. Once you've done a manometry, it may show, there may be two provocative maneuvers that can be done. We may be diagnosed a postprandial swallow that could be indicative of a behavioral disorder or rumination syndrome. Or when you do manometry and there's multiple rapid swallows, what has been shown is that there's an inverse relationship between the multiple rapid swallows and the acid reflux burden. This is particularly useful with a negative diagnostic workup, and that's one of the reasons that SASA does the manometry. With this multiple rapid swallows for patients that undergoes the fundoplication, it may predict late post-op dysphagia for patients that are undergoing a RAP. This just indicates, a normal manometry, and on the right-hand side, what you see are the various types of achalasia. So I've now, as per the Lyon consensus, they categorize the manometry findings as being as adjunctive or supportive evidence if you have a hypotensive gastroesophageal junction, if there's a hiatus hernia or esophageal hypomotility, which is important. Often patients with severe GORD, they have just low motility at the distal esophagus. Those three features are often used as an adjunct to make a diagnosis of GORD. So that's the Lyon consensus that I think we all need to know, and I know that it comes up often in the fellow exams. Moving on to a barium swallow, especially for patients that have severe refractory GORD, as I spoke about earlier. This barium swallow provides information regarding an esophageal stricture and function. And like I said, it's important it helps us to exclude the mimics of refractory GORD. We may see this where it's typical bird's beak appearance, indicative of achalasia, right? And may show a stricture, right? And then finally, the final test that we may refer for patients with severe GORD, it is concerns really of delayed gastric emptying, so gastric emptying studying. So gastric emptying studying, it's a gold standard for the evaluation of gastroparesis, and it's a 4-hour study. And delayed gastric emptying study, if there's more than 60% retention at 4 hours, or more diagnostically, if there's more than 10% retention at 4 hours, that's a positive gastric emptying study. That's important because, as indicated earlier, delayed gastric emptying, gastroparesis can cause reflux symptoms and persistent reflux symptoms. So this is an example of a gastric emptying study, and as I've indicated, more than 10% retention 2 hours, and more than 60% retention 2 hours, and more than 10% at 4 hours. And then just to indicate that the possible causes of persistent GORD-like symptoms and possible corresponding tests that we could do, and I think this correlates to what I've indicated in the course of this presentation. This diagram pretty much summarizes what I've said, and in terms of our workup, patients having reflux symptoms, is it proven or it's unproven? If it's, and then we proceed to the process of doing a scope, and in patients then possibly proceeding to having a pH study. A few examples I've indicated is patients have non-GORD esophageal disorders. We would consider functional heartburn, reflux hypersensitivity. We'd also have to consider other important mimics that I spoke earlier in the presentation that are EOE, piloesophagitis, and that you'd have to treat accordingly. Also to remember a possibility of a motility disorder. Yeah. Thank you very much. I think that's all that I have to say. Thank you. I'll stop sharing my screen.
Oh, well done, Nasief. It sort of stated most of the things that we wanted to hear. Are there any particular questions? Let's look in the chat. So it doesn't seem that there are any questions. So I'll just maybe make a few comments. We have a bit of time. So Nasief has gone through an algorithm of diagnostic workup scenarios. In your practice, you won't necessarily have to go through all of those. 80% plus of your patients will probably only require, if ever, maybe even mostly an endoscopy once your symptoms suggested that they should get, and they meet all the criteria, and then the treatment. In a small percentage of patients, we will then move on because the symptoms don't often settle completely, or there is another reason why we have to move beyond endoscopy. So I just want to maybe put a scenario to you. So you may have someone who's maybe sort of middle age, late 40s, early 50s, have reflux type symptoms. You give them standard PPI therapy. They do respond, and then you will continue them on their journey. Some of them, however, may have partial response. So, and that's where it comes in. Once you give them 40 milligram daily of whatever, maybe omeprazole or any of the other ones, they continue with it. And as they settle after 3 months, usually you would start to reduce down the dose until you get to a PRN sort of scenario. And invariably, these patients always come back with recurrent symptoms. So Nasief, what do you suggest we do in that particular instance where they have responded, but as you reduce down and taper and go to a PRN basis, they then relapse? What would you suggest we do to the patient at that point?
Yeah, thank you very much, Dr. Fredericks. Actually, it's a topic that we had discussed and presented. I'm not sure which forum it was last year. And the issue of PPI deprescription. The Western Cape governments in 2019, they did this massive audit on the usage of PPIs. And I prepared a presentation which our division delivered as a provincial webinar. And what we found out is that PPIs account for roughly 1% of the total pharmaceutical budget in the Western Cape. And the situation, I'm sure, is the same other parts of the country. And part of the issue really is exactly what you said, is that patients have, and the commonest reasons why people stay on PPIs is, we found was that persistent reflux symptoms, where patients were on PPI they had GORD, the symptoms got better, they stopped the PPI, and the symptoms came back. So part of what may happen is this issue of rebound hypersecretion, whereby, and I don't quite have the presentation at hand now, whereby rebound hypersecretion is where patients produce, as a consequence of long-term chronic acid secretion in the stomach, they develop hypergastinemia. And hypergastinemia is a mechanism by which is ongoing stimulation of acid production, and hypergastinemia results in several issues, most notably a relapse of symptoms. So the recommendations around the PPI deprescription is that the first step one should do is, number one, see, can you halve the dose? So if someone, for example, was on 20 milligrams of omeprazole, can you halve the dose? If they were on 30 milligrams lansoprazole, can you halve the dose? If there's no alternative dose available, for example, there's no 15 milligrams of lansoprazole or no 10 milligrams of omeprazole, you can take the PPI on every other day. In the Western Cape government right now, they've now introduced pantoprazole, an oral version, where there is 40 milligrams is the equivalent of 30 lansoprazole. So now they can actually take 20 milligrams of lansoprazole. So the first recommendation is to then see, can you halve the dose? And then you see how the patient tolerates the lower dose for a month or two. And then after you've then half the dose, can you then perhaps take the medication intermittently? Eventually, over a period of a few months, and now the issue of hyperglycemia is now settling because you're using lower dose of the PPI. And then after a few months, you can then take sort of a PPI on demand. And a PPI on demand has actually been shown to be an effective strategy for people with mild to moderate GORD. But often going from taking BD PPIs to PPI on demand, the patients don't tolerate that. You kind of have to go through this PPI tapering mechanism, as I've just indicated.
Okay. Now, I get that's an important point and an important discriminator as well. The other point that I really just want to also add on here is don't forget your lifestyle modifications. Patients will have terrible reflux. They will avoid certain things, but as they take their medication and start feeling better, they go back on their old bad ways. So and often you'll find if you take the history why they are having persistent symptoms is that they have gone back and they're eating and drinking and do the things they used to do again. So just being mindful of that. And the other important thing that you've mentioned is make sure your patient takes the PPI correctly 30 minutes before the meal at least. And we find, even in private, patients take PPI as and when they want. There is a question in the chat, which I will now. Which group of patients with GERD should undergo screening for Barrett's? Now, see if you want to answer that.
Which under patients? Sorry, I'm just looking in the chat. For the reflux surgery or?
Now, with the GERD, must be screened esophagus.
I mean, especially patients that have chronic symptoms. So the topic that I presented was reflux, but especially pretty much as patients develop refractory GORD. So the patients that have refractory GORD, these are often patients that have ongoing reflux symptoms. They've been on PPI for a long time, often months, often years. And if they have, number one, confirmed diagnosis of GORD objectively, those patients, and they have ongoing chronic symptoms, those patients should be screened, because we know that the pathophysiology is related to chronic acid exposure to the lower esophagus. Ernst, I'm not sure if there's anything else you'd like to say on that.
Just as there is a sort of exclusion to this, because we know that patients with Barrett's, they have a lot of acid exposure, but they don't often have a lot of symptoms. So it's often the patient with little symptoms that often have the Barrett's, but there is that group of patients that have been identified that you have to do a scope on to exclude Barrett's esophagus, and those are usually it's the Caucasian males. They're usually middle age, around 50. They're overweight and they often smoke. So that's the sort of once you get to the Barrett's talk, you will get to this, but that's probably the type of patient that you want to do endoscopy straight off the bat. Okay. Other questions?
There's a question there in terms of anti-reflux surgery. I can just speak in terms of, there's what happens in the literature, and we work closely with Galia, and we actually had, when we presented this, and also when Sasa presented GORD in terms of at the beginning of early parts of last year, we were discussing with the upper GI surgeons which patients do they operate on. And I see Innocent has pasted in the group. And the only real patients that Grootsky is operating on is patients that have volume reflux. That's where the base evidence is for. The issue really comes is that if you have someone that had a pH impedance study or a pH impedance study, they've gone through the full diagnostic process as the algorithm as being presented tonight, and they have clear objective evidence of GORD. They are following the diet, they're on the PPIs, and they're still having issues. Those candidates or patients should be considered. But the problem really is, if according to Kala, if you're operating for symptoms alone, that's a bit of a minefield, and I don't have enough experience. Perhaps, Ernst, you can say from your perspective, especially in private practice, which patients are operated in private.
Right. So,
sorry, can I had a slide on my presentation that I've prepared on which candidates are good for anti-reflux surgery. And there were a few criteria. The one was if patients don't want to be on PPIs, and definitely, or they can't be weaned off PPIs, if they have a non-reducible, large, more than 3 centimeter hiatus hernia, which is the major pathophysiological mechanism resulting in their GERD, that would be another good option for them as well. And then regurgitation. Remember, PPIs don't treat the regurgitation aspect of of reflux disease. So it treats the acid symptoms and the volume. It can fix the acidity of the reflux, but not the regurgitation. So those were also some of the extra indications or patients that were good candidates for anti-reflux surgery.
So Jessica, just to make it a bit clear, patients who are on PPI, who are doing well on PPI therapy, who are relatively young and don't want to continue PPI therapy, those are good candidates to do. You don't sit and operate on a patient that's not doing well on PPI. They will not do well after the op as well if they don't do well on PPI, okay? So let's make that just clear. And patients with volume reflux certainly should have, and if they have quite significant regurgitation, they should also have. A hernia per se is not an indication for an operation, right?
Yeah.
So what are the other questions here?
Sorry, Ernst, I think it's important to note also just from because I'm doing my info with SASA and we're looking at the pH outcomes in the context of GORD. And the one thing that I've learned is that often patients that are very, very symptomatic and taking the PP and they take very symptomatic, they can never stop the PPAP. Often those patients don't have GORD. They often have NERD or one of the other reflex hypersensitivity. But often it's the patients, the true GORDs. They're often not the ones that have a whole host of complaints.
Yeah, we're still scrolling through the list here of things. Anything that you guys spot that I don't see? PPS, don't treat. Okay. For patients who relapse after initial response, should I place them on lifelong therapy? I think we've answered that. Yeah, and if there are no other sort of questions from the floor, I think we've done reasonably well. Jessica, it's a pity. I mean, you've prepared such a, your talk was well prepared and sort of well set out, and it's a pity that you couldn't present it today, but I'm sure you will get another chance to do that.
Thank you so much. Yeah, I did concentrate a lot on pathophysiology and how you can tailor your medication specifically for individuals, so more precision medicine and GORD. So I did a little bit more into the pathophysiology, but I think Nasief did a really good job. So thank you so much for saving me.
Right, Nasief, thank you. Thank you for standing in and stepping up. We really appreciate it. And all of you who have joined, made a contribution, we say thank you to everyone. And we say thanks to EHCO, University of New Mexico, and the EHCO India team for the support. All these recordings will be available on the Gastro Foundation website, so please don't forget. And we also, lastly, want to say thank you to the Gastro Foundation. Please remember, in 2 weeks, it will be Dr. Aslam Parker that will talk on the approach of dysphagia. Thank you all very much.